This week we're going to focus on the rise of bioethics. Where did it start? Why did it start? And how has that influenced the way that it's gone since then? So in particular, we're going to focus on the researcher-subject relationship, because bioethics arose not in the context of how a general practicing physician should treat his or her patient, but rather how researchers should treat human research subjects. It really began after World War II, when we put the Nazis on trial. So the Nuremberg trials more generally put many Nazis on trial for war crimes of differing sorts, but we want to focus on the Nuremberg medical trials, which occurred as part of the Nuremberg trials in 1946 and 1947. The Nuremberg medical trials put particularly medical researchers and medical doctors on trial for their experiments on the different prisoners in concentration camps through World War II. The result of the Nuremberg medical trials was the Nuremberg Code. This code put a heavy emphasis on informed voluntary consent of research subjects. So even though it has about 10 different principles, the main focus is that the research subjects have to consent to be researched on, they have to be informed about what the research will entail before they give that consent, and then also that consent needs to be voluntary. And by that we mean that they can't be told either consent or we'll lock you away or something like that. Additionally, it needs to be voluntary throughout the research, meaning that it can't be the case that a researcher tells the subject, once you've consented, you're committed to doing this research all the way through. A research subject should be able to leave the research trial at any time. The Nuremberg Code has become the basis for future ethical guidelines throughout the world, including the Belmont Report here in the United States, which we read last week. Interestingly enough, during the Nazi medical experiments, and also prior to them, we had similar sorts of things happening here in the United States. So for instance, in 1941, you had experiments on orphans at the Ohio Soldiers and Sailors Orphanage. You had experiments on the mentally handicapped at New Jersey State Colony for the Feeble-Minded, and at a mental institution in Illinois. None of these were particularly consensual on behalf of the research subjects. Additionally, there were studies that were done on the soldiers themselves, U.S. soldiers themselves, who were told they had to do this as a requirement of being a soldier. It was their duty to do it, and if they refused to do it, then it was just like refusing a normal order in the military. And perhaps most famously is the Tuskegee study. That study started around 1930, although it really kicked into gear in about 1932. And it was a 42-year-long study of untreated syphilis in 399 African American males. So in this study, what they did is they found these 399 African American males, told them that they were going to be treating them for their syphilis, but instead didn't treat them and just actually studied what happened when syphilis went untreated. So they lied to these people, and they also particularly selected a vulnerable population at the time. So it's important to keep in mind that this sort of treatment of research subjects was not unique to the Nazis. It's not like they were the only ones who were mistreating their research subjects. This was very common throughout the entire world when they were doing research. Research subjects were sort of treated just as tools. So how could that be justified? How could we justify treating these research subjects merely as tools? And this isn't to say that we're going to want to justify it. Certainly, most of you are probably appalled by the idea. But we do want to know what sort of ideas, what sort of arguments were going through people's minds that made them feel justified in doing these sorts of experiments. Moreover, we want to ask these sorts of questions because they're important for understanding what sort of research is justified now, even if it's not coercive. So, Hellman and Hellman talk about a general ethical theory called utilitarianism. According to this general ethical theory, an act is right when it produces the greatest balance of happiness to suffering for all those affected. What's important about utilitarianism is that it's impersonal and egalitarian. By that, what I mean is that every person that is affected counts for one, and no one counts for more than one. And also, you don't count yourself as more important than anyone else. So for instance, if I'm deciding to do an act of a particular sort that's going to heavily affect me and a bunch of other people, but it's going to affect me negatively and affect everyone else positively, I can't say, oh, well, because it's me doing the action, the negative effect to me matters more. I have to count that equally with everyone else. For our purposes, we want to focus on the fact that utilitarianism emphasizes beneficence and non-maleficence rather than autonomy or justice. So, in our four principles that we discussed last week, beneficence and non-maleficence included the idea of benefiting people, that was beneficence, making them better off than they otherwise were, and then non-maleficence, not hurting people, not making them worse off than they already were. And this is all that utilitarianism really cares about: maximizing happiness and minimizing suffering, maximizing benefits and minimizing harms. As far as autonomy and justice go, only insofar as those are benefits or harms to people. For instance, if you say, I don't want to do something and I make you do it anyway, presumably me making you do it harms you. And so sometimes I should listen to you because listening to you will make you happier, or not listening to you will make you suffer. And that's when it counts. But it only counts insofar as it's a harm or a benefit. Utilitarianism generally likely justifies situations like Omelas, where we stick one kid and make him or her suffer greatly for the benefit of a lot of other people. Because so many people benefit, and they benefit so much, then even though the suffering of the one child is so severe, it's probably outweighed by the benefit to all the other people. Additionally, utilitarianism is going to be able to justify effective research. So research that actually results in good things for people in the future, even if it's coercive in the first place, can probably be justified by utilitarianism. And this is why Hellman and Hellman find that utilitarianism is incompatible with the proper relationship between a physician and a patient. However, they do think that utilitarianism may represent the proper relationship between a researcher and a research subject. The researcher's duty is to study a drug or study multiple drugs or study a particular therapy and figure out whether or not it's something that should be used for all people with that particular condition, or many people with that particular condition. And so her job is to maximize the sort of happiness that she can by producing results that show that a particular therapy or a particular drug is really effective or is not really effective and therefore shouldn't be used. Finally, applying utilitarianism to the context of medical ethics, what we need to think about is that if research will or is likely to result in a great benefit to many people, then maybe it is right to sacrifice the few for the many. A particular example might help here. So the Nazis did a lot of research on hypothermia. Particularly, they induced hypothermia in prisoners and then tested different things to see what could be used to fix it and also kind of see what it did to people. Now, while we might think these sorts of experiments were horrible, and in fact they were horrible, if that hypothermia data was actually useful for combating hypothermia in the future, so that many people who got hypothermia didn't die, even though they would have, or otherwise were benefited by it, then under utilitarianism, it may be justified to have used those prisoners for that sort of research. So this is just one way that we might think about justifying research in this way, justifying research even when it hurts the person or even when the person doesn't consent to it. Again, we want to keep this in mind because what we're going to find is that oftentimes the research subjects don't benefit from the research anyway. They're just being harmed by the fact that they're in a trial of some sort. And while even though we ask for their consent now, we might still think that sometimes it's not justified because the results aren't useful. And so the pain inflicted on the research subjects doesn't get outweighed by the benefit that's given to everyone else who may benefit from the research. Let's also talk about the need for research subjects. So the article on cancer studies was very informative in telling us how problematic it is for researchers to actually get subjects, voluntary subjects, to conduct these studies nowadays. So first of all, what the article talks about is that they're not able to get enough subjects voluntarily. For cancer in particular, only 3% of adult cancer patients volunteer for the studies. These adult cancer patients don't volunteer for the most part for differing reasons, including the fact that they fear they're going to receive an inferior treatment or that they're not going to receive a treatment at all. They might fear getting a placebo, for instance. And they also are worried about the added burden. They've just been told they have cancer. They've just been told they have different options for how to treat it. It's probably overwhelming for them, and telling them, oh yeah, and you could join up with a study that may or may not help you, in fact may make you worse, but could benefit people in the future, is a hard thing to take in at that time. Additionally, because you can't get enough research subjects voluntarily, many studies just never happen. So we get some data from the same article. Only half of the studies sponsored by the National Cancer Institute enrolled enough research subjects to have the chance of producing a meaningful result. Only 1 in 5 studies actually publishes its results. And this is also because there's burdens on the physician researchers themselves. So the article talks about how it's overburdensome for the physician researchers. It's very time consuming to have to go to institutional research boards and get approval for studies. They don't get compensated very well oftentimes for the research that they're doing. And in fact, they may even lose compensation by doing the research rather than just doing normal treatment. So for all these reasons, there's concerns about trying to set up research in a way that will actually be effective while simultaneously respecting the fact that we think that people should have to volunteer for these studies and not be forced to do them. So that brings us into a discussion of clinical trials themselves, and in particular of randomized clinical trials. So the article by Passamani and also the article by Hellman and Hellman discuss randomized clinical trials from differing perspectives. But before we talk about that in detail, we want to figure out what a randomized clinical trial is in the first place. So let's use a simple case. We want to know, is drug A more effective than drug B? Well, that's a really difficult question to figure out because there's many complexities that can make it hard to answer in a general form. So for instance, I could give drug A to one person and drug B to another person and see what happens, but it may be the case that there are other differences between that person that got drug A and that person that got drug B that caused drug A to work better than drug B, for instance. And so randomized clinical trials are aimed at trying to get an answer to that question by overcoming the complexities. So the general way they work is that you get a group of subjects together and then you randomly divide them, in our example, into an A group and a B group. Of course, randomized clinical trials can have more than 2 groups, but we're only using 2 for our purposes here. So you randomly divide them into an A group and a B group, and then prescribe them the drug given whatever group that they're in, and then study what happens. This attempts to control for the many complexities by not intentionally selecting for them. So for instance, if there are random differences between people that make drug A more effective for some people but not for others, your hope is that you've captured people in the A group that both have that difference and that don't. And so you'll be able to get overall results that would be useful for everyone. Final thing to remember here is that some of these studies, although not all of them, can be what's called blinded. So a study can be blinded in different ways, and it can be single, double, or triple blinded. And blinding basically involves leaving certain participants out of the loop regarding particular information. So for instance, the patient may be blinded by not being told what particular drug he or she is receiving. The researchers themselves, or at least the ones that are actually doing the tests on the patients, may be blinded as to which drug that patient has. And the reason for this is so that they don't accidentally include bias in their decision making or in any of the work that they're doing. But randomized clinical trials do not need to be blinded, although many are. So what are some of the problems with clinical trials? Well, as we saw with Hellman and Hellman in particular, and we'll talk more in the next lecture, it may violate a physician's obligation to her patient. So there's different ways to understand what exactly a physician is required to do for his or her patient, what sort of obligations he or she has to his or her patient. And under one understanding of that, she's supposed to do everything she can in order to benefit her patient. And unfortunately, sticking her in a trial may not do that, because when you stick her in a trial, you can't change the sort of drug she's receiving just because she's reacting poorly to it or it's not as effective as it should be. Otherwise, the trial itself breaks down. An additional problem with the clinical trials is conflicts of interest. So we saw, interestingly, in the article on cancer study, that one of the proposals that these authors were making was to increase the financial benefits to physicians for participating in studies, because right now they're not getting reimbursed enough to make it worthwhile for them. On the flip side, as we'll see more in the next lecture when we talk about the death of subject 13, when you stick financial benefits into a research study, when you make it beneficial for a doctor to actually get people into his or her research and conduct that research, then you might make the research more problematic in differing ways, either by enrolling people who shouldn't be enrolled or by doctoring results in differing ways. Additionally, there's a conflict of interest because many of these researchers are going to be physicians at the same time. So they're going to be treating the patient both as a physician and they're going to be examining the patient as a researcher. And unfortunately, as we saw earlier, that might mean that they have conflicting ways of going about it. In one case, as a researcher, they're focused on a utilitarian way of thinking. So they're thinking about doing the drug trial in order to figure out what drug is more effective so that they can save more lives in the future. But as a physician, maybe they should be focused on their particular patient that's in front of them and give him or her the best treatment that they can. Finally, we have questions about valid informed consent. So informed consent is not merely signing a piece of paper. There's a lot that goes into it, and we worry about whether or not particular forms of supposed consent really are consensual. So for instance, what if there's financial benefits for people to volunteer for a drug study? Well, in that case, you might worry that the people who are really poor, who need the money the most, are in some sense being coerced into doing the study because they don't have a whole lot of options available to them. They really need money, and this is one easy way to get it, and so they're sort of forced into doing it and forced into sticking with it no matter what. Additionally, you might worry about coercion due to power imbalances. So if I go to my doctor, I expect my doctor to be an expert who's going to help me and who knows more than I do about my illness. And when he or she tells me, hey, you should enroll in this drug study, then I might listen to him or her without a whole lot of thought because I'm expecting him or her to do what's best for me, even if maybe he or she is not. And then finally, you might worry about coercion to prevent early withdrawal from studies. So remember, the informed consent has to be voluntary throughout. So that means once I sign the piece of paper to sign up for the drug study, I can still get out at any time during the study if I want to. But you might worry that doctors are telling people in one way or another that they're not actually allowed to leave the study, and because of that, they're being coerced into sticking with it. Finally, let's talk about the features of a properly designed trial. So Passamani in his article describes 3 features of properly designed trials. First is informed consent. Of course, this follows from the principle of respect for persons. Second is what's called clinical equipoise. So clinical equipoise is the idea that none of the possible therapies that are going to be researched have been shown to be better than any of the others, according to a consensus of doctors. So in our previous example of testing drug A versus drug B, we'd be in a state of clinical equipoise if doctors, generally speaking, agreed that drug A and drug B were equally effective, or neither of them was more effective than the other. Passamani also argues that clinical equipoise in particular forms the ethical boundary between moral and immoral research studies. If there's not clinical equipoise, if in fact we find out that drug A is much more effective than drug B, then it'd be wrong of us as researchers to continue to give drug B to people when we know drug A would help them more. And so he thinks that if you're in that sort of state where you actually know one of the drugs is better than the others, then the research has to stop and you have to go ahead and give the patient the best treatment possible. Clinical equipoise in general follows from the principles of beneficence and non-maleficence. It's about maximizing benefits and minimizing harms, because we don't want to be giving people a worse treatment than they could be getting, generally speaking. And then finally, his third feature is that the research needs to be useful. As he puts it, it needs to ask an open question that is worth answering for therapeutic reasons. So there's many questions that might be worth answering for general reasons, but these ones need to be worth answering for therapeutic reasons. So for instance, if I want to know whether drug A is more effective than drug B, that's a therapeutic reason, because then I know to prescribe drug A to patients rather than drug B, if it turns out that I'm correct. The feature of useful research follows from the principle of justice. And it follows from the principle of justice because it says that we shouldn't just be doing research on people without any sort of good reason for it. And justice in general requires us to sort of spread out burdens and benefits across the board. And so it should be the case that people are actually going to possibly benefit from this research, and it's not being done merely for the sake of science, for instance. So that's all we have for this lecture. When we move on to the next one, we'll be putting this sort of 3 feature of properly designed trials to the test in the context of the death of Subject 13.